I can assure you there will be no twerking coming here today, but I really wanted to thank Rajam for having me here today. It's a topic that I'm very passionate about, and obviously all you guys here are passionate about it as well. The panel we had just before here, I mean, this is huge expectations now to try to live up to what they just did. I thought it was awesome. I'm going to give you a little bit of a perspective from my story as a clinician, because I think as we've talked about yesterday and even through today a little bit, it's important to know where you come from as a clinician and your story that you bring into the encounter and the interaction with a patient. I've trained in physical therapy. I graduated physical therapy school in 2003, and then it was endless pursuit of the alphabet soup. I wanted to be a Jedi manual therapist where I could just watch a patient walk and diagnose a facet issue from across the room, or just wiggle a joint and just, fix people like they were cars, like we used to treat people, and unfortunately still do today. In my manual therapy training, I went into fellowship training, which was a great experience, and that's where I thought I was going to really culminate my skills and become just that Jedi manual therapist. And of course, it was great training, great clinical reasoning, and I still use manual therapy, so I'm not trying to bash manual therapy here today. But my encounter with pain science in a pain science course is what really changed my course of my career, because I still recognized, as I was getting all these great skills in manual therapy and clinical reasoning, there were still people that were failing, despite all these great skills I was having or thought I had at the time, and still fail with a strict manual therapy only approach. And I think we've learned this weekend that we need to hear the experience of the patient and not pull them into our story, a manual therapy story or a strict massage therapy type story, or whatever backgrounds we have. So again, it's important to know our story. A little bit about me personally. Those of you who follow me on social media probably have been inundated with pictures of my daughter, Evelyn. She's 6 months old. She's been the best thing that's happened to my wife and I, Mallory. Mallory's a physical therapist in the ICU, so she deals with a lot more scary things than I deal with. I haven't killed anybody or at risk to kill anybody, thankfully. She does a lot more dangerous type care, but interesting applications of pain science that we won't go into today in her care. As I've been able to interact with a lot of folks in this room, and Gillette has been a big one that I've got to talk to with understanding the patient's experience, I used to kind of propose myself to patients as being an expert. I know what you're going through. I understand pain. I'm an expert in pain. And Gillette really kind of put me in my place. I heard her talk about it, and she said how kind of insulting that is to a patient to hear that from a clinician, to say, I understand what you're going through. I mean, some of the stories we've heard this weekend, and I'm sure stories you've all heard in your clinical practices, the only person that really has expertise in their pain is the person experiencing it. And I think too often we try to ascribe that we're experts to their experience. Now, we can be experts in trying to best understand and walk with that person through their experience and do our best to kind of integrate our expertise of understanding pain and things with their experience. But too often we try to ascribe expertise and again, enforce our story and our narrative upon the patient. So I think we can do better in that route. But if we look at the neuromatrix model, and this comes from a Katz and Melzak article that you're probably all very familiar with, this is kind of the best model we have. I know we can argue and talk, there's probably more to it than this, but this kind of really encapsulates the human or lived experiencer. And then what we think about is, well, what does healthcare give us? Healthcare gives us a bunch of people that categorically, to understand a patient and understand a field, we kind of cordon ourselves off into a very narrow body of knowledge, which again gives us ability to understand that narrow body of knowledge. But unfortunately, humans don't work that way. Humans are all encompassing. They are this, they are not that. But again, an example of this, I worked in a very big health system and had a patient who had widespread pain that started with a foot injury and had various things, but she came to this health system that had multi-specialty abilities to specialize in all these different things that you're seeing on the screen today. And I looked at her chart from a 90-day period. She had encountered our health system 75 times with different, and some of these were phone visits, I'll have you, but 75 times where nobody was putting these pieces together for her. They were all seeing her at their little island of, you're going to go see the immunologist, and you're going to go see the endocrinologist, you're going to go see the pain physician, you're going to go see all these people. And it was so hard because I tried to educate this patient on how this all goes together. It's all one human experience that, yes, cordons itself off into different parts of that experience, but you'd get them pulled into different diagnostic categories and different things where they would still get labeled and not really seeing the big picture. So it's a hard system that we're working against. Obviously, there's a lot of groups that are doing a great job to integrate a more holistic way of looking at healthcare. There are some multidisciplinary pain programs out there, but unfortunately, they're not, they're the exception rather than the rule, and hopefully that'll be changing in our society. This is a diagram most of you are probably familiar with from explaining pain, but it kind of talks about this tissue problem versus pain problem. I know that kind of overly dichotomizes things, but we're good as physical therapists and often healthcare people to understand when it's that tissue-based acute pain scenario, but unfortunately we've made this assumption that even when people have pain, there's this tissue issue. I know as a manual therapist, my training was to find the pain generator, was to find what was causing that patient's pain. It was to reduce it to some comparable signs in their spine and treat it and get rid of it. And what we have happen is what I like to call the land of 1,000 stories. So as a manual therapist, it was very joint-focused, very disc-focused. I know in massage therapy, there's different ways of thinking about, fascia and trigger points and knots and muscles and, subluxations in the spine and other professions. And there's just a million different stories. But unfortunately, these are all stories that we as practitioners have. And as you heard here on the panel today, they aren't the stories that our patients carry with them that are really the true stories that we often see that are modulating their pain experience and causing them to have such difficulties with overcoming some of these pain issues that they have. The article I kind of clipped there, and I'm not going to go as into depth as Dr. Abkarian did beautifully with his fMRI studies, but we know that when this pain situation becomes chronic, it's not as much of a tissue-based issue. Now, can we affect pain by tissue-based techniques? Absolutely. We can modulate it in short-term time periods with peripheral-based techniques. But a lot of the pain in these situations are from emotional centers. And Dr. Abkarian, like I said, pointed it out beautifully. The problem is, do we even ask about that stuff with our patients? Do we even ask what's going on in your life? What's going on? What are you losing as a result of your pain? I think I heard a dialogue between Jason Silvernail and Gillette about workers' compensation and about how we're always worried about the secondary gain issues with people, but yet we don't really recognize what are the primary losses that these patients feel when they're in workers' comp. The loss of their identity as a firefighter, their loss of their identity as a wife, as a provider for their family, all these different things that people lose, which makes sense when we see people and hear these narratives, why we might see that these pain processes are more housed in the limbic system, in these emotional areas of our brain, because it's a very emotional experience, I think, for caregivers and for pain patients as well. The big thing with our stories is we understand that pain is a very emergent experience, and this is obviously a very brain-bound diagram, but there's a lot of things that go into a patient's pain experience, and to resolve it to a 0 to 10 scale, I think this week, and that we hopefully realize that's kind of a ridiculous endeavor when we consider the complexity of pain. And for a person to just take that language, or to take all that goes into the complexity of pain and try to reduce that to a language that they can understand and comprehend to put forth to their clinician, I think John Quintner's and Milton Cohen's paper about, by contrast, the only persons who expertly know pain are the persons in pain, yet their efforts to communicate such expertise is limited by the lack of knowledge to express their pain. So we don't have good words in our language to express a lot of the things that we heard the pain panel here today say. But it's interesting in our language how pain can represent a lot of different things. So it doesn't just stick to pain that you see in the clinic. We'll get the breakups, the pain of a breakup, or the pain of losing someone. How many people here have seen patients shortly thereafter, their pain situation got worse after the death of a loved one? Yeah, tons of hands going up. And these are things that previously to me, understanding that whole complexity of pain, my story was about the joint and the tissue that I was going to identify. I might give that a passing glance, but I was going to really try to hone into what joint I can start manipulating or mobilizing. So very limited ability to help people when that was their driving factor oftentimes. And then I put this one in for my friend Mark Powers, the pain of, in our sporting culture, we do have the pain of loss as far as Super Bowl loss. So sorry, Mark, I had to do that to you. But if you look at the history of healthcare too, it's interesting that the story used to really take center stage with patients. Doctors used to be like in your home. They used to do home visits. They used to sit and talk to you and really, and I'm not saying they don't do this now, and I know most of my friends who are in primary care and in medical practice would love the opportunity to have time to speak with their patients, so I think we have to be careful, getting too hard on our medical colleagues. But we've really moved from that kind of personal care that used to define medical practice back before we had all this technology and different things. The doctors used to know what you were doing in sports and different things, and used to know your life and used to know you as a person. And it's not that some doctors still do an amazing job doing that, but there are so many things in their work demands that make it extremely hard to become a connected human with another human in that. So when we have the advent of MRIs and technologies and all these pathways and computers and all these different things, and I think the quote here from that article, biomedicine's quest to identify the source of the pain in the tissues excluded the lived experiencer's expertise. So we have a patient here who's just waving on the other side of this wall that's being built up by this procedure and this pursuit to really take one singular causal disease model that we're going to find some pathology that's going to explain a complex experience that you heard here on these at the table. It just isn't going to happen. Now, occasionally there are obviously painful conditions that might fit this type of mode of treating, but that's often the exception rather than the rule. I'm always interested in one of my biggest things, and you hear this, my friend Corey Zimney and I have talked about this as well, is there's such a lack of qualitative research when it comes to pain, and just to really understand patients' perspectives on pain. There are some, a little bit more than what we've seen in the past, but if you read Ben Darlow's work and other folks who do a lot of qualitative research, you get to hear what patients' perspectives are on their condition. And you hear quotes like, he doesn't seem interested, I haven't any access to saying how I feel or what it's like. I mean, these are things that you would think would be extremely important to understand what a patient feels and what it's like for them in their shoes, especially after what we've heard today, yet patients aren't being heard. And often they don't even get the ability to tell their stories. So we have physicians who are going to interrupt and redirect patients in 23.1 seconds, and opening statements are only completed 23% of the time. I've also done a similar exercise that Allison did of trying to say, tell me your story. And I was sat in on Joletta's talk, or Joletta's work with Peter O'Sullivan, and I thought that was going to be the biggest failure on earth because Joletta's the most pain science knowledgeable person, so I was just waiting to see this interaction not go as planned, and Peter beautifully pulled out some amazing things from her just by listening, and it was just leading her through a conversation. But we don't give patients the ability to do that, and it's a shame. But what informs their story as well is the information on the internet. There's a recent study that looked at all the information, I think this was on chronic back pain or back pain in general, and there's very limited to absolutely zero integration of psychosocial or pain biology factors when it comes to some of the stuff that people are looking at on the internet. We've all had patients that read Dr. Google, come to us with all kinds of interesting things that they feel are the roots of their problem. Now, obviously, we have to listen and affirm, acknowledge that thought, but oftentimes the internet can be more of an enemy than a friend when it comes to healthcare. And then when we survey physicians, when they're talking to patients about their problem, they have inconsistent beliefs and behaviors around low back pain. And when they carry their own fear avoidance beliefs around the back, it's going to influence how they interact with their patients. It's interesting, I've been an experiencer of low back pain myself, and I've herniated a disc, and it's interesting, I've had to have that experience of almost going into that fear avoidance and catastrophizing mode myself. So it's been a good experience for me to really see how it's easy to slip into that mode of protection and fear if you don't know any better. And unfortunately, we take that fear and can really bring it to our patients as well. So this is most of you are familiar with this diagram, the fear avoidance diagram from Vlayan and Linton. And really, truly, when we hear these patients' narratives, often the common thread we hear and the common thread of getting them back to existence where they have control of their pain is a priority toward life goals and acceptance and different things that really bring them back to meaning. And how often do our stories pull people into the exact opposite, where we need to fix, we need to find the pain generator and manipulate it or inject it or do whatever it is to it to fix this. And I'm not saying we shouldn't do pain modulating procedures, but man, do we often lose sight of that giving that patient an ability to have maintained valued life goals in a pursuit of those valued life goals. So when we're hearing patient stories, are we really asking them what their priority in life is? What are their valued goals? What brings them joy? What brings them excitement? Often that's left out of the story altogether. This is an article from Chapman and his colleagues in the Journal of Pain in 2008. Now, we could spend probably a whole semester of college discussing this diagram, but it's just to know that the nervous system doesn't function on an island where it's a very neuroimmune endocrine correlated system where all these systems cohabitate and work together to create a sick human who's really suffering and struggling with their condition. And the interesting stories that you hear in the clinic, I heard a tragic story a year ago that still sticks with me today, and I'll often have discussions with patients of how your past experience can influence how your nervous system and things, perceive situations going forward. I had a patient who had CRPS in 2 different areas of her body and widespread pain and different things. And when I talked to her about past experiences and things, she just volunteered, and this was about 3 sessions in, that while she was a child, twice her stepfather attempted to drown her in a bathtub. So just imagine, put yourself in that person's shoes. The most safe place you should have as a human being is your home. And yet, your life's being threatened in your home. How does that set you up as a human being to pursue and go forward in life, to take some of the stressors and strains that life is inevitably going to give to us? So it's interesting, the articles we read, that we can start seeing how these nervous system issues can change with patients, and we can quantify it with QST testing and different sensory profiles and things. And the interesting study at the bottom left there shows fibromyalgia patients really struggle in this study to positively modulate their pain with positive emotions. They really struggle, in my opinion. Could that possibly be just the representation of that learned helplessness we sometimes see with patients, where they don't have things that they can really glean positive in life because they've had so much negativity and struggles and difficulties that they've had. But we see their stories affecting their biology, and too often we sit where we see these fMRI studies and we see these qualitative studies, and we don't pull these two together and really understand the human being as a whole, that human experience that patient has will have a very big effect on that fMRI scan. So we can't really separate those two out. Obviously, we have to do it to study it, but human beings don't work that way. We can't coordinate off. Now, I'd love to be able to put a mixed method study of qualitative and quantitative where we did fMRI scans and then tracked the narrative of patients, where we could see how these people progress in their story of pain and how it can affect the person staying and recovering from pain, or what in their narrative can be the common themes that we see that can have them to where they're in that chronic persistent pain state. This won't come as any surprise to most of you, but we have so much language in healthcare that just really, if we understand that whole pain biology and the integration of the immune system and endocrine system, I would definitively say our words and actions can be highly inflammatory to our patients. Bones out of place, pain equaling damage, bone on bone. I can't tell you how many, daily when I see patients for new evaluations, I'm regularly hearing language like this from them. So we're still doing a terrible job in healthcare with our language with patients, and I think that's something we need to improve so much and has so much more room for improvement. But one thing to think about with our patients, what if even the thought of moving was the physiologic equivalent of watching a good horror movie? A lot of these patients carry huge amount of fear in their story. They have a huge amount of past experiences and some of the language behind that past experience that often, unfortunately, they've gotten from their healthcare provider that doesn't make them feel comfortable bending over. If you give people, and I've given people the jelly donut story about the disc, and I forever want to smack myself in the head for doing it, but when a patient bends over and they're feeling like, gosh, I hope the jelly doesn't ooze out of my jelly donut disc, I mean, you're not going to really be providing an environment for that patient to be confident in their body again. They're going to be worried about, they become that flexophobic patient who just carries their back with them for activities and doesn't use it. But again, I claim no innocence with a lot of this language. I've had to clean up my act quite a bit. So it's interesting, we've talked a little bit about the social structures that dictate pain. This is kind of a funny video from Candid Camera way back in the day. It's a Prudential commercial, but I think it just goes to show the examples of how our patients are social beings and often get pulled by social factors that it's important for us to know about. So let's look at this video.
The gentleman in the elevator now is a candid star. These folks who are entering, the man with the white shirt, the lady with the trench coat, and subsequently one other member of our staff, will face the rear. And you'll see how this man in the trench coat tries to maintain his individuality, but little by little, he looks at his watch, but he's really making an excuse for turning just a little bit more to the wall. Now we'll try it once again. Here's the candid subject. Here comes the candid camera staff, 3 of them at least. And this man has apparently been in groups before. Now, here's a fella with his hat on in the elevator. First he makes a full turn to the rear and Charlie closes the door. A moment later, we'll open the door, everybody's changed positions. Now we'll see if we can use group pressure for some good. Now, in a moment, on Charlie's signal, everybody turns forward. Notice they take off their hats. And now, do you think we could reverse the procedure? Watch.
So obviously that's a funny take on social.
Oops,
hold on a second. It's a funny take on the social pressures, but I think we underestimate the power of cultural and other social factors that can really pull people into certain behaviors in certain ways that may be following the crowd that may or may not be helpful for their pain experience. So I think it's just important, again, to know the social setting that human being in front of you functions in so we can have an idea of what specific pulls they have on them. Excuse me. But as PTs, this is a study that was just coming out before publishing in January in Physical Therapy Journal, but it basically had PTs try to estimate what they thought the start-back risk stratification is. So start-back is basically a screening tool, for those of you who don't know, that can stratify patients based on, I believe, it's a 9-point questionnaire that basically puts people in the low, medium, and high risk. And a lot of clinicians, especially and ones that think we're very adept at the pain science, feel like we should be able to predict that with our examination and just talking to people. And unfortunately, the results of this show that PTs are very poor at allocating patients based on their judgment without having this tool on which are they the medium, low, or high risk patient. And their competence, they don't really feel competent in managing patients when they're in higher distress, which is unfortunate because a lot of the patients we see in persistent pain are in significant distress. So it's obviously a hole in our practice that we need to improve on, and it's conferences like this, of course, that are going to help us get there. One of the great concepts that I think is important to understand is what Cohn and Quintner have discussed as the third space. So it's this space where the patient and the clinician can come together and create a collaborative environment of exchanging their expertise with no judgment, where it's just a place of open exchange. For those who don't know Matt Lowe, he put an article out recently about dispositional approaches with it, and we'll talk about that here in a second, but he's a good follow on Twitter, by the way. Matt and I have had the ability to exchange some thoughts over Twitter and social media, but I think this really looks at kind of understanding that we have to understand ourselves as a physiotherapist or as clinician, that we're an embodied agent that comes with all the same factors that our patients comes with. Social and cultural background, different things and thoughts, cognitions and perceptions that we need to understand are our checked-in biases before we come into that encounter and recognize the patient does. Hopefully we are setting up a an interview and a subjective interview that gets to the bottom of all these factors to the best of our ability. Sometimes we're not going to get there in one encounter, of course. And we create this intersubjective space with the patients that really can help a shared meaning and a shared narrative be creative and get that patient on a goal-directed plan of care. Asking a patient, what are the things that are valuable to you that you would like to do, that you're currently struggling to do? We'll talk about more questions than that, but I think it's a good concept to think about instead of just immediately pulling people into your narrative of whatever it may be. For me, it was manual therapy, and my questioning really focused around how I could get myself down to a manipulative technique or a manual therapy technique, maybe stepping away from that. And maybe I get there if it's the right patient at the right time, but maybe manual therapy is the last thing I need for that patient. Maybe they need to learn, have different strategies. So again, instead of fitting patients to treatments, fitting treatment to patients, but I think we could do a lot better. So as part of Matt's thought about disposition, so he talked about, we look at pain as this kind of linear causal model where there's this cause and effect, where we're going to identify, especially in biomedical viewpoints, there's this disease or pathological process going on that we should be able to identify and create this outcome of pain. We know that's not the case. And maybe a different way to look at it is there's different dispositions that exist in a patient's life that pull them in different directions. And this kind of threshold dotted line on the left is when we have these things in life that can stack up and maybe create environments that predispose people to having symptoms generated from those dispositions adding up. These are just some that I pulled from Matt's article, but these are common things we'll see in patients. But we should think about that biopsychosocial load that our patient undergoes. I think previously a lot of us probably looked more at the biological loads that people were undergoing, unless you're in more of a behavioral mental health field. And we need to understand more of the psychosocial loads that a patient undergoes to really best understand their situation. So getting to know the patient's story, there's a lot of great resources out there. Kendall Linton in Maine had a article. Gifford has many good things in his Aches and Pains book. Was able to get an article with Ina Diener and Adrian Lowe. But there's a million questions you can ask, and this is just a mnemonic of attitudes, beliefs, behaviors, compensation, ergonomic issues, diagnosis, emotions, family, work, and motivation is one that Wijma et al. Added to the mix with understanding where that patient is on their readiness to change. I think too often that's a part that we've missed from clinical care where we just assume that, yes, patient, you need to exercise because I'm the expert physical therapist or physician or whoever that thinks you should do that. And obviously patients don't do that. Patients don't just miraculously listen to everything we say. Sometimes, but I'd say that's, again, the exception rather than the rule. But these are just some questions. I'm not going to read them out to all of you, but the one question that I always think is the question that should be in everybody's subjective exam is, why do you think you hurt? Or based on your experience thus far, why do you think you're in pain? And some of the interesting answers that you'll get back from patients can be shocking. I've had patients, I think I have cancer and nobody's looked for it yet, or there's been various things. I'm sure we could go around the room today with some of the interesting things that maybe Dr. Google or other sources of information gave patients that honestly the biggest thing is getting them more adaptive. I've had numerous patients where the degenerative disc disease story or the joint crumbling story, when you can normalize that experience by showing patients the normalcy of that and how it's okay to move with that. In fact, it's probably the best thing to do is to learn some good active movement strategies. That can be one of the best treatments out there. But again, we don't know if we need to treat that unless we ask what the patient's perception of their problem is. So really understanding that attitudes and beliefs portion of the equation is hugely important. Behaviors, when you hurt, what do you do? Compensations, economic issues, that's one that obviously we've got to be careful that we start interjecting that day one with a patient. That's often something that might be a day 2 or day 3 thing, although some patients volunteer that information day 1. I've had patients where, gosh, it looks like you're under a lot of stress. You can see they're angry, and then the story about how they're about to lose their job or they're really struggling to pay their bills, and the lovely workers' compensation system that we've heard about today that really can be a huge barrier in our patients' lives of getting well. There's just a lot of things we can ask a patient, but again, to try to know that whole dimension of them as a human being, and again, not a X-ray or an MRI finding or what pathoanatomical or biomechanical explanation we're going to throw at them, I think is important. Some other helpful questions that I've found to really get to the bottom of what might be going on in a patient's life or driving some of these issues. Greg Lehman yesterday in his comedy routine talked about, I kid, Greg, of course, it was a great lecture from Greg. What are the things in your life that might be sensitizing at the time? So what was going on in your life around the time when pain began can be a powerful thing that I've had patients say, well, it was right around the time my spouse passed away in hospice care, or it was right around the time I was going through a huge breakup, or I was in a huge stressful situation recently where a kiddo left home for the first time going to school at college, and it was hugely stressful, and she was struggling to integrate herself back into that. So those are things that you just, unless you again ask, you will not know. Where do you see yourself in 3 years is a powerful question that can sometimes bring out the Kleenex with patients because they don't see a lot of hope in their situation, and it can just give you an idea of where they're at with maybe some goal setting or not lack of goal setting, or where their self-prognosis is, because a lot of times research will tell us that one of the best predictors of how a patient will do with us is their expectation of how they think they're going to do with us. So understanding some of that, their self-expectation and maybe what their expectation is with you can be very helpful. But what do you do for fun and enjoyment? That's another one where patients often will come back to you with a blank stare, like they haven't had fun and enjoyment in their life in ages, and just the thought of it, they can't even recall. Often I've had patients who don't even recall the last time they've done something for fun and enjoyment. So again, you start pulling in these different parts of their human experience of pain to kind of see if you can put a story together and a narrative together. When you start doing pain education in these treatments that we've been learning about, how do you frame it to fit their narrative? I think too often we have these canned pain science education nuggets that may not fit the patient situation, and I think that's really the true art of pain science education, is really being able to fit that education in a way that makes sense with their specific story, with their specific experiences, and not maybe our favorite analogy or metaphor. And I'm sure Mike Stewart would have different things to add to that as well. Why do you think your body hurts? We've already talked about that. Are you angry at anyone or anything about your pain? I think that often can bring out different factors of frustrations and worker compensation systems, a lot of different things that can really, or feeling like they've been wronged or have had issues that they need to possibly get over from an employer or different things before you're really going to make headway with that patient. And then what do you think it'll take to make you feel better? That's another interesting one where you can, somebody needs to cut this tumor out of my brain. I've had people say when they didn't have a tumor, which was interesting, but you'll hear some interesting stories with that and interesting parts of a patient's story that, again, can help us put the story back together for a patient, or at least help them form a narrative that you can make sense of things with them. So I'm actually ahead of time, which is a first for me, but bringing the humanity back to healthcare, I think often what we see with our patients' abilities to tell their story and to get all of these important things that we heard from our panel today is we need to understand the human being that's behind those symptoms and understand what's in their life, what they're experiencing, what's going on that really drives a lot of the 0 out of 10 or 15 out of 10 that the patient tells us. Again, I think it's a ridiculous reductionist way to encapsulate the complex experience, again, we heard today. Shut up and listen, I think, is a great advice I tell for students, especially students that I mentor in clinic, is we too often don't shut up and listen. And just stepping back, tell me your story. Let's get we had Gillette Skype in at a course that I taught up in Michigan, and we just let her tell her story, and it was 20 minutes. And if you have an hour of a patient encounter, if you give somebody 20 minutes to tell their story, it gives you 40 minutes to still do some good stuff with the patient. So I think obviously we have patients that we need to skillfully guide and steer into a narrative that allows us to get some things done. But I think we have to be careful to not let that patient really get everything out that they need to get out and discuss the whole part of their human experience with pain that drives them to your clinic that day. Sometimes it's the best treatment you can offer a patient. I've had numerous patients. I'm sure I can talk to a lot of you guys here who will tell you, you're the first person that's ever listened to me. And it's sad that that's the case. And often, how many people have they seen before they get to your door? They have lists upon lists of physios and chiropractors, and I probably have been on that list for patient. When I was in, treat just a tissue mode to fix all pain, I'm sure I was on that list with a lot of patients. So we can all get better at that, and we can all get better at lending a listening ear to our patients. And I'm going to leave you with a quote, and then I'll finish for today. But we really need a cultural change. And one of my favorite quotes that I use in all my courses is we really need a cultural change. It's no longer enough to know about anatomy and pathology. The biopsychosocial approach opens up a whole new perspective on how people behave and cope with illness. It reveals the limitations of our treatment and of our professional skills. It exposes us to the difficulties and stress of dealing with emotions. We must accept that patients are not neat packages of mechanics or pathology, but suffering human beings. Professional life may be much simpler if we stick to physical treatment of mechanical problems, but healthcare demands that we treat human beings. And that was Gordon Waddell, who unfortunately passed away, I believe, last year, which is a shame because he's been a pioneer in our field of understanding low back pain and chronicity in low back pain. But we are treating human beings, and we cannot strip them down to being simple pathoanatomical, biomechanical beings. We have to see the whole human that's behind those symptoms, because the most empowering thing for a lot of our clients today was to be heard, to be listened to, and be guided on a value-based approach back to their lives that they enjoy. So thank you very much for having me. I appreciate it.
You just made a lot of friends because we're going to be able to get to lunch a little earlier. But first we have Q&A. So we've got a couple of microphones, so if you have some questions or comments that you'd like to make, please raise your hands nice and high. Right up front.
This is kind of cheating because I talk to Mark all the time, but so from a lot of feedback that I've gotten over the years, clinicians are often at a loss for what to do when patients are sharing very difficult parts of their story and difficult parts of their narrative, and things that cannot be changed, like past traumas or past very stressful experiences. So do you have advice for clinicians on how to deal with that in that moment?
I think as a physio, I have to be careful of recognizing where my scope of practice lies and not trying to delve into counseling people about that type of issue for them. But I do try to plug people into, that's part of you who's now taken that experience forward, and that affects you going forward. It's tough waters to tread because as physios, I think and that's all I can speak for, is it's not comfortable ground for many of us to stand, because it's not how any of us were trained to really look at a patient. It was very much looking at mechanics and movement, and again, not that that's wrong, but it just definitely doesn't encapsulate the complex experience that we see with patients. So when we're getting some of those tough statements and tough, past traumas and things, if something that I can at least plug them into how that affects them, and then I've been blessed to have psychology colleagues and social work colleagues close by where I can help talk to patients about, we do know that this type of thing is really helpful if you discuss this with somebody, because this can help, you kind of desensitize your system and get things back down to where you're better able to cope with some of these stressors that you got going on in life. So just being able to recognize when you have some experts in that area to lean on, but at least being able to, as a healthcare person, to not just throw those experiences to the background and not at least help that patient conceptualize that affects them and who they are and how that will affect them perceiving things going forward. Yeah.
Another question right up here.
Thanks, Mark.
Yeah.
I'm curious if you'd be willing to share some of your story of how you moved from tissue-based to caring about the patient story.
Well, I think it's through failure, really, is what really drove me to and again, I don't want to say I'm not tissue-based, because ankles still get sprained, discs still acutely herniate, so there's times where I regress back into tissue-based treatments, and it's not to say, I'm just talking to people about psychosocial factors when they have a sprained ankle, and they pretty much just need me to treat their sprained ankle. But after treating numerous patients and just not getting across, manual therapy did not work. I worked with some pretty high-level manual therapy clinicians. I can parallel Gifford's experience when he worked with Jeff Maitland in Australia, and Jeff Maitland, amazing manual therapist and did amazing contributions, but Gifford saw this patients that weren't getting better in his clinic, and I saw patients with amazing, guru therapists that I was able to mentor underneath not get better with a strict manual therapy approach, and often those type of, factors with a patient were kind of shoved aside, and how do I get to, a treatment threshold where I'm going to start wiggling a facet around or manipulating something or whatever it may be for that manual therapist. So it was just recognizing that narrative did not work for patients, and there was obviously more out there. And in my pain science course in fellowship was really where I really said, aha, that made sense, that why these people didn't fit that narrative, because the research, when you're looking at an emotional thing and you're trying to treat, that's really modulated by the emotional and coping mechanisms of a human being, yet we're trying to do it all through mechanical means, you're not pairing the intervention up with the problem. And I think, can you change it though with temporarily? I mean, we see all kinds of temporary short-term effects with manual therapy and a lot of peripheral interventions, but in that population sometimes. But what makes long-lasting life changes, I don't think Gilletta would say it had anything to do with the manual therapy technique, and I don't, again, see that approach, again, not being wrong, but it's not necessarily the answer for a lot of those people who are dealing with a lot more complex situation than one we're going to try to reduce to, a facet issue or some sort of biomechanical fault in their back or shoulder or something. Does that answer your question?
We have another question up here in the second row.
Thanks a lot, Mark. That was great. Do you have any suggestions or strategies that work for you to help bring your colleagues along this journey? Because that's really a barrier in my world, on doing all this extra work on learning and changing my practice, and then having the patient go next door and get all of the same old same.
Yeah, I wish I had a solution for that one, because you can do the best pain science, education, and really feel like you connect with the patient, and it can be destructed in a 10-minute encounter with a neurosurgeon or a colleague. I've had, a lot of physios who are still very mechanically based, strictly, and that can really, I've had conversations where if I've been referring a patient, I try to be proactive and try to introduce that, this patient is fearful of body structure and different things, where I might try to cue, if I know they're going to go see another colleague, where so I'll try to cue it up to just show, talk about central sensitivity and different things that might be going on in that patient's case to hopefully help that clinician not slide back into. But it's a tough transition. I don't know, many of you guys who've done it here probably can, but to delve out of your comfort zone where it's just resolved to a joint in a manipulative technique, that's a scary place, because it's like your clinical comfort zone, and it's really, it can be tough for clinicians to want to, go to that being uncomfortable, not knowing type scenario, where I think manual therapy gave me this false sense of knowing, and being comfortable not knowing was a big thing for me. But how to get that across to colleagues, I think this kind of thing, and mass media, social media, all these things, and continuing education courses and people pushing this information out, hopefully changes things. I don't know how we can look at statistics of chronic pain and the opioid crisis and all these things and think we're doing good in healthcare with pain. I just think that's ridiculous. So,
Mark, just to piggyback off of that question, there's a lot of different professions represented in this room, and also observing online, and some of us are licensed healthcare professionals, but then there's a whole range of complementary professions. From personal trainers and massage therapists and rolfers and structural integrators and blah, 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 right?
yeah.
Now, there's a lot of us are seeing people that are either already working with healthcare professionals or who are not currently, because perhaps their insurance cut them off or something like that. And there are times when somebody will come to us saying, my doctor or whoever said, I have this, and it's a very biomechanical thing. And so it is not our place to say, no, you don't. But we need to work with them.
Yeah.
And so I'm wondering if you could speak a little bit to the challenges of facilitating that interdisciplinary conversation so that we can try to connect a little bit more easily, and maybe, and maybe find each other, so that, if I get somebody coming in and say I have a diagnosis, maybe I can refer them for a second opinion to somebody that maybe has a different perspective.
Yeah, so you're saying for to be able to communicate with a physician who's given that information? Or
physician, PT, whoever.
That's a tough one because the PT or the physician needs to have the humility to hear you, which sometimes I can speak for myself, sometimes I didn't. But I'll tell you, the personal trainers and massage therapists who are very pain science informed, I think are great resources, and I think I would love to see more in healthcare to help our patients and get them with a more constructive narrative around their pain and kind of pull them away from some of that stuff. I think you can lead patients to resources and, some of the YouTube videos and different things that can help patients maybe reconceptualize those things. Or as Greg said, instead of like coming at a patient and being abrasive with what they've been told, saying, okay, yeah, but let's see what we can do and work constructively here, and here. The great thing about that, your degenerative disc is we know that actually movement and all these things, we have some great research. So using research can be a helpful, powerful tool for people. I know that's maybe not always what is, with the personal training profession and massage, but I think a lot of your physio friends would be happy to arm you with any of that stuff to help patients reconceptualize things maybe in a more adaptive way of looking at it as opposed to some of the fear-inducing stuff that we see out there. So it's a tough one. I think we have such a culture of still with the biomedical way of looking at it and those narratives that we give to patients. But I think sometimes, and Gifford says this in his books, it comes a time where you got to stop talking, you got to start doing. So I think sometimes with personal training, for instance, you can confront a person with their strength and show them how much they're able to do. Maybe you use more of a graded approach and a graded exposure way of looking at it, but you can start getting these people to where they start seeing their abilities and you strip the fearful narratives away from them and start moving them forward. But as far as communicating with your physician colleagues and physio colleagues who might be giving them a narrative that's not more helpful, I think you can reach out and hopefully maybe have a conversation that you can see if you can find some common ground with them, or you try to find some like-minded individuals in your community, some PTs or some fellow personal trainers or doctors who might be some good referral sources that you can bounce some ideas off of.
We have a question up here towards the front. Okay. Let's take a question online since she's got the mic.
Yeah, we have a lot of questions, so I think you've answered a couple of them already, but one question that Donna is asking is if you can clearly hear the patient telling you that they are not intrinsically motivated to engage in a process of collaboration, what might you do?
If they're not ready to engage in collaborative approach, there are some times where despite best efforts, despite your best work at educating patients and despite best things, people might not be in a place in their life. I don't just default to that when I hear somebody do that. We'll try to see if we can do some, start showing people instead of trying to talk people into being collaborative. We do some motivational interviewing and different things. I think that's a huge skill that all physical therapists and healthcare people should do. How do you get somebody who's not motivated, is not even thinking about changing their behavior? How do you move them to behavior change where they're going to do something? But that's where you got to structure conversations to have the patient talk themselves into change and not you directing them forcefully into change. And that's as easy as that may sound, which probably doesn't sound that easy, but it is extremely difficult. I've been fortunate to work with Eric Kruger, who's doing his PhD and does a lot of work with ACT, and he's doing his PhD in psychology, where I'm trying to glean better skills of that. That's a skill I think we can all develop, and it's a skill that is constantly in need of refinement. But that would be the number one thing is, can you see if you can structure conversation to where you can start getting people to see why, based on their life, it might be valuable for them to change behavior and then move them forward in that case. But if you're still running into walls, then there's times where I've said to patients, look, this may not be the right time for you, because in the past I would just default back to manual therapy mode and cracking joints and massaging and doing different things that would give them temporary relief, but then 30 visits later, the same pain came through the door, nothing changing in their life, they were the same. And I've just decided now that what I feel the best interest of that patient is not being the 21st therapist to do the same thing over and over again and expecting something different, and maybe saying, hey, this might not be the time for you right now. I'm going to be here. I think we have some great things we can do, but I don't think that's the approach that's best for you now based on X, Y, and Z that we just talked about today. And if you're ready in the future, I'm always going to be here for you. I wish you nothing but the best in your pursuits, and let me know if I can help you again. So that's, I guess, my approach with it.
Let's take another online question, and then we've got a gentleman in the second row in the plaid.
Yeah, so another question we got from the same person, Donna. She kind of, along the same lines, wants to know what professions might we refer to for that patient who may be struggling to become more intrinsically motivated to take ownership over their experience.
Professions you could refer to,
Yeah.
you know, that's you know, psychologists, social workers, folks that, I mean, it depends on what we identify might be the barriers in that patient's, you know, taking ownership. I often find that communicating with my physician colleagues, I'm lucky to where I can just walk downstairs and talk to the doctor. I just had a patient the other day who's fibromyalgia. She's angry, she wants to be fixed, and she has just a lot of personal, social, relationship issues going on that really are apparently a big driver of a lot of sensitivity. And I walked downstairs with my physician colleague and said, hey, this is what I was just told from Mrs. Smith. I really think we need to plug her in to psychology and get her kind of engaged. But I don't know if there's a one-size-fits-all who to refer to. I think it's what that patient demonstrates as far as need and where their specific barriers are. But I think if you can find a way to get a unified message, that's why I'm lucky to have kind of an integrated healthcare team where we can all sing the same message to the patient instead of having somebody pulling them back into, you know, biomedical, your tissues are fragile and you're going to, you know, ooze the jelly out of your disc kind of narratives.
Thank you.
Thanks, Mark.
Yeah.
So my question was for, you know, in terms of, so you revert back to that, you know, tissue-based stuff for things that are attributable to that. Are there factors that you identify that would lead you to talk about these types of things as well, even in the acute stages of injury? And if so, what are those factors?
You just see how somebody's coping with their situation. I mean, what do you think's going on? I mean, you have patients where you can visibly see. I mean, you get the ankle sprain patient who's like in a wheelchair where mom's wheeling the kiddo into the room and won't bear weight, won't let things be touched, and where you just see this, you could just see this pretty significant reaction to what doesn't seem like it should be if we just look at it mechanically, what went on. So those are some of the, you know, things we can see, but just talking to the patient and hearing, you know, fear and what do you think's going on with this? What do you think you need to get better? Why do you think you hurt? And you just get some of these things that start coming out with these acute pain patients like, whoa, this is, you know, not a very adaptive view of things. We need to start, you know, doing the standard things we do to help tissues heal, but that's where I engender confidence. Like, you know, that swelling you have is awesome. That's your body doing its, you know, appropriate things where we, you know, really point out the positives with the patient instead of doing what we used to do is just, here's your problem list, patients, of all these faults I found in you, and these are all the things we need to correct. And I mean, again, that just steers people further into the wrong direction. So trying to, instead of a problem list, maybe make a positive list of all the things that you can find good with that patient that are going well, and then, again, just positive reassurance, getting them moving, really making sure you educate them about tissue healing and how the body's designed to do that, and all the good things we know that the human body's capable of doing, and not, again, pulling them into that narrative that, to me, steals their self-efficacy when we're, you know, telling them that they're damaged goods and broken beings.
We're going to take one or two more questions from our online participants. Or is...
Yep. So we have one more question, and that is, how do you handle the fatigue that often accompanies chronic pain?
How to, like, the fatigue as a clinician or the fatigue as a patient?
I'm not 100% sure. Maybe
Well,
both.
As a patient, I mean, there's a lot of things, activity pacing principles and different things we can do. You know, understanding, you know, when we're dealing with conditions such as chronic fatigue syndrome, they're kind of neuroendocrine immune wired a little bit differently to where things, you know, they don't have a good ability to, you know, get into that arousal phase of the endocrine system and do, you know, or sometimes they're tapped out. I mean, obviously there's a lot of complexity that can go into fatigue, but, you know, teaching people, you know, that actually getting into exercise and being active, and there's some decent research with chronic fatigue syndrome, some trials that if we get people engaged in exercise, that can help. Now, obviously, It needs to be something that isn't like going to a trip to the dentist for the patient, trying to find something that brings them some enjoyment, that can maybe help tap into some descendant modulation with their, top-down abilities of their nervous system to help out with things. But trying to get them active and showing that it's safe to be active, and that usually the narrative around them has not been active, and they've, when they can see that they've, inactivity and deconditioning and all the things that spiral into that cycle, hasn't been changing things the way they've been hoping to, that maybe there's an alternative path for them. But again, not just forcing that narrative upon them, trying to construct a conversation where you're having them help them come to that conclusion on their own, can be huge.
Great, thank you.
Yep.
All right, I know there were more questions. I saw some hands that were starting to go up, but that is all we have time for at the moment. So let's please show your appreciation to Mark Kargela.
Thank you.